welcome and thank you for joining us on today's webinar. My name is Hannah. I'm the Director of Patient Services at Verita Neuro. And with me is Dr. Nasir, who many of you know very well from our previous webinars and possibly from our in-person consultations, online consultation that Dr. Nasir is going through with every patient who is receiving medical evaluation from us. Today's webinar is a little bit different compared to what we did before. Usually we have one of our patients joining. I hope many of you have seen those webinars before. If not, they are available on our Facebook and on our YouTube channel. So we will encourage you to go back to those stories and see the webinars when our patients are sharing their experience with epidural stimulation and other treatments we offer under Verita Neuro in the Verita Neuro facilities. Today, however, we would like to focus a little bit more on the science behind epidural stimulation. Dr. Nasir will present and try to explain a little bit more to all of you about the benefits, the mechanisms, and all the applications we can use epidural stimulation for. Dr. Nasir, he's a medical doctor. He's been working in the field of regenerative medicine and neuromodulation for the last 12 years. He's actually one of the first doctors, if not the first doctors in the world to combine epidural stimulation with regenerative medicine. So today he wanted to share with all of you a little bit more about the treatment options we have available. Doctor, welcome.
Yes, thank you very much, Ms. Hannah. Hello, everyone. Good morning, good evening. Thank you for joining us today. So we would like to briefly talk about the science behind epidural spinal cord stimulation. As you may remember, we actually, some of you may remember, we had spoken to many of you before, but today we would mostly focus on basic science on epidural spinal cord stimulation. How does it work? And what are the potential implications and applications for this kind of treatment? And I will be representing the medical department from Verita Neuro, and I will be happy to take your questions at the end of the conversation. So maybe I can start by sharing my screen. I had compiled a short presentation. So I think my screen, Ms. Hannah, can you see my screen?
Yes, we can see your screen. Before we start, I just wanted to encourage everyone to ask questions. You can leave your questions both on Zoom and on our Facebook page in comments. So we will definitely address all of these as we progress through the presentation.
Thank you. So basically, in its simplest form, epidural spinal cord stimulation means the spinal cord stimulation at the epidural space level. It is an application of low frequency electrical currents to a specific segment of the spinal cord. So each segment of the spinal cord is responsible for a specific function. For example, the cervical spinal cord is responsible for the respiratory function in the form of phrenic nerve, and also some of the functions in our upper body. Similarly, the lowest part of the spinal cord, called lumbar spinal cord, or in a sense lumbosacral spinal cord, is responsible for motor function in the lower body. So basically, we use a small electrodic stimulator to approach the epidural space and implant the stimulator to give electrical currents, control electrical currents to the spinal cord. So this approach is actually being used in other modalities. It is actually a very mainstream type of treatment for neuropathic pain. This is how it was developed. It can cause a condition which is called basically a paresthesia, to block the nerve signals going to the brain. We use a slightly different approach than the one being used for nerve pain, and which I will explain in a while. And basically the stimulator contains two components. One is um, a stimulator, which is also called implantable pulse generator, which we can see here. It's a small computer, basically, which also contains a battery pack, and it generates electrical currents. The second component is the 16-plate electrode array, which is implanted into the epidural space. And then there are two leads which connect the IPG with the electrodes. So this is what it looks like on the post-operative X-ray scan. So implantation of electrode array into epidural space. So this is the epidural space, and the location of the electrode can vary, basically depending upon what do we want to target. So most of the patients are with the paraplegic spinal cord injuries, where we target the lumbosacral spinal cord, which is actually the lumbar spinal cord, but anatomically it is located under lower thoracic vertebrae, which are normally T10, sometimes T11, T12, L1. So it depends on each patient. So before, of course, any surgical preparation, we do extensive work, including very comprehensive MRI scans to go through all the anatomical landmarks, and we do define a specific location we want to target during the surgery. So in this specific case, it is T11, T12, as we can see the last two ribs, basically, and the thoracic level. And the location of the stimulator or the implantable pulse generator IPG could be anywhere really, but the manufacturer recommends it to be in a flank, basically. So it's either in the anterior-posterior anterolateral abdominal wall or posterolateral abdominal wall. So it could be normally it's implanted in the posterolateral abdominal wall around the hip area, just under the skin into the fatty tissue. Mm-hmm.
Doctor, can you explain? I believe many of our patients wonder how the location is being chosen for each of the patient. How does it correspond with the level of injury? Do we implant the stimulator over the injured spine, over the healthy spine, and why?
Mm-hmm. So we don't target the injured spinal cord, basically, because I will explain the next slide about the exact mechanism of action. How does it work? So basically, the purpose of the implantation is to target a healthy spinal cord segment below the level of injury, because as a result of spinal cord injury, there is a disruption of the signals. Upper motor neuron pathways are functionally kind of like disconnected, and so basically our job is to kind of like bypass the spinal cord and approach the spinal cord at a lower level to provide electrical stimulation and allow the patient to supraspinal control over those last function. I will explain in the next slide in a little bit more detail. Mm-hmm. Regarding the location of the pulse generator, it's not very important. But if we go for the original indications, which is either the anterior or posterior abdominal wall, then it makes the stimulator 100% MRI scan compatible. So patients can go through MRI scan very safely. So that's why we go with the original recommendation and we implant at the recommended location. So today we will basically focus on two major areas, last functions, which are the motor function and autonomic function. So basically, from motor function, I mean somatic motor function, which are the skeletal muscle function, and then the autonomic functions, including the blood pressure regulation and the bladder function. So this is the major mechanism of action of the epidural spinal cord stimulation. So I will try to explain. So this is a cross section of our spinal cord, and spinal cord can be divided into two major sections. Basically, the interior frontal part of the spinal cord is called a ventral horn, which is also called the anterior column of the spinal cord, it contains the motor neurons in the front side. The dorsal column of the spinal cord, which is located on the posterior side of the body, is it contains the sensory neurons. So although our aim is to get a motor output or to get the muscle contraction through the stimulation of the motor neurons, which are located in the front part, it is not possible practically to implant the stimulator at the front part, and it doesn't work. So basically, we approach the epidural space from the posterior side and implant the stimulator over the posterior column of the spinal cord, which contains basically the sensory neurons. So once we give the electrical stimulation to the sensory neurons in turn stimulate the interneurons, which are located between the motor neurons and the sensory neurons, and then ultimately the motor neurons are indirectly stimulated. Once we see the stimulation of the motor neurons, we see the motor output, which is the stimulation of those spinal nerves, the motor nerves, and then each spinal nerve at each segment of the spinal cord is responsible for a specific muscle group or individual muscle. So based on what kind of segment is being stimulated, we get the motor output in the corresponding muscle groups. So for those patients who are suffering from paraplegic spinal cord injuries, and the aim is to stimulate the lumbar spinal cord or restore the function in the lower body, we target the lumbosacral spinal cord, which contains 5 lumbar nerves from L1 to L5 and 2 sacral nerves, S1 and S2. So those 7 segments of the spinal cord, which are quite tightly packed in the lumbar and the sacral spinal cord, are responsible for majority of the skeletal muscle functions in the lower limbs, or almost all of the muscles are being supplied by those 7 segments of the spinal cord in the lower limbs. So if we can successfully give electrical stimulation and precise electrical currents to those specific segments of the spinal cord in the lumbosacral spinal cord, we can see the movements coming back in almost all of the muscle groups which are required for patients to walk. And another thing is, so the earlier question from Ms. Hannah about why don't we implant the stimulator over the injured spinal cord. So basically, for epidural stimulation to work, the electrical current has to go through the whole cross section of the spinal cord. Basically, the electrical currents have to move from the posterior column to the anterior column, from the back side to the front side, to reach to the motor column of the spinal cord. And if we implant the stimulator over the injured spinal cord, this means that there may be a lot of inflammation, scar tissue build up inside the spinal cord, maybe a lot of cystic changes in the spinal cord. There could be transaction. So all those neurons, which are functional actually, are anatomically intact, at least in the lumbar spinal cord, are injured as a result of injury. So if we implant the stimulator over the injured spinal cord, the electrical currents from the posterior column cannot be transmitted to the anterior column, so we don't get the motor output. So that's the major reason it is not a suitable treatment to actually target the injured spinal cord. It has to be over a healthy spinal cord below the level of injury.
Just to sum up, I think we explained this a lot in our previous videos. Regardless the level of injury, if as long as it's since we're implanting the stimulator in the lower thoracic and upper lumbar spine, it doesn't really matter if the injury is at C level or T level, as long as it's above this area, which contains those neurons responsible for motor functions in the lower limbs, we should be okay. So we need the healthy spinal cord below the injury level to be able to receive the signals that the stimulator is helping to transfer from the brain, amplify it to deliver back to the healthy spinal cord around the lumbar area.
This is correct. And so once we give the successful electrical stimulation to the lumbar spinal cord, then patients can, so it allows patients more control over the muscles, and patients can use the residual signals which are passing through the spinal cord to control the movements in the lower body. So in almost all of the cases, 99% of the patients, there is, although the complete is, maybe the injury is functionally complete, but anatomically it's incomplete injury, which means there is almost always some connectivity through the spinal cord. Some connections are still there. So patients can use those residual pathways, residual connections to control the movement in the lower body with the help of the epidural stimulation.
Doctor, let's come back to the surgery itself. Now, of course, we're talking about implanting the stimulator and stimulating the designated area in the spinal cord, which is the lower lumbar level. But this, of course, is not the complete treatment. Could you elaborate a little bit more about the importance of the epidural stimulation mapping? What do we do to help the patients regain control over the movements, have more volitional control, more voluntary movements rather than just contractions coming from the direct stimulation?
Correct. So mapping is basically the fine-tuning of the electrical currents to the spinal cord. As we know, in every patient, there are some residual signals passing through the spinal cord, but the signals are not strong enough to produce the muscle contractions. So during the mapping process, basically, we try to stimulate each segment of the spinal cord, each of those 7 segments, which we aim to stimulate with very precise electrical currents, frequencies, intensities, and pulse width. So there are 4 parameters, basically, we have to combine together at very precise quantities to give precise stimulation to the spinal cord. So during the mapping process, basically we try to see what is coming from the brain through the spinal cord and see what is missing, and then we try to provide the missing electrical currents using the stimulator. So we start by simple muscle groups like major flexors, for example, hip flexors. And we kind of know what is out of those 7 segments of the spinal cord, which segment is responsible for hip flexors. And we try to use the upper electrodes, for example, this one here. So we try to use one of those electrodes to stimulate each segment of the spinal cord. And we can use those 16 electrodes individually or in combination with each other. They also have polarity, which means they are either positive or negative. They can function at different frequencies, different electrical currents, and then we can also combine those electrodes together in more complex programs. So we start, for example, by turning on one or a couple of electrodes, and we see what kind of muscle group is being contracted using this specific electrode. And then we keep finding different electrodes for different muscle groups, and then we keep combining those electrodes into what we call programs. And then at the end, our aim is to have a walking program or stepping program. So stepping program means maybe there are multiple electrodes turned on, which are giving electrical currents to multiple segments in the spinal cord for multiple muscle functions. So that's the most complex program we aim to find. And once we find this final program, the aim is to use the program to train the muscles during locomotor training.
Mm-hmm. This, of course, sounds a little complicated if we're talking about it from the medical perspective. And indeed, mapping, it is a complicated process. However, in practice, it really, for the patients who are working with us, it really is a form of physical therapy. So this is the process of mapping and programming of the device is really a collaborative work between the doctors, therapists, and patients. So patients are the key element in the process of mapping, because they are the one also trying to produce the movements by thinking of performing certain movements, and the therapists, by mapping the device, they are trying to add the missing signals and add the missing power. So we can have better and better results over time. It is a complicated process, like I mentioned. Usually, since the stay with us is 35 days, the duration of the stay is really mainly aim to complete the mapping. It's an individual process, and there is no one pattern that we can use for each and every patient. In fact, we have to perform a separate, very personalized mapping for each and every person, because everyone responds to different frequencies, different intensities of the electrical current. So usually we are completing 4 hours of mapping per day, which is, like I said before, a type of physical exercise. It's quite tiring, especially in the initial weeks when the patients are starting to move their limbs again, sometimes after a very long time without any voluntary movement.
Yeah. So epidural stimulation, similar to the motor function, can also be used to regulate the autonomic functions. So as we know, one of the major issues as patients with the spinal cord injury suffer from is the dysfunctional cardiovascular function, where they are unable to regulate their blood pressure. There is loss of bladder and bowel functions and other autonomic functions, including body temperature regulation. So epidural stimulation, although not the major focus, can also be used and tweaked basically to stimulate some of the areas which are located in the sacral spinal cord, below the lumbar spinal cord, to regulate autonomic functions, including blood pressure regulation and bladder and bowel function. So I have included blood pressure regulation and bowel function as two of the functions we can improve using epidural spinal cord stimulation. So basically, in the blood pressure regulation, so there are which are called descending sympathetic spinal pathways. So basically, the autonomic nervous system control center is located in our brain. There is what is called supraspinal control, which means beyond the spinal cord. So basically, brain is directly responsible for those functions. Although those functions are called autonomic functions, they are not entirely automatic. Basically, there is still a command center located in the brain which is monitoring and regulating those functions. So as a result of the injury, there is disruption of those sensory feedbacks, for example, or motor control over those lost functions by the brain. So those descending sympathetic spinal pathways, which basically start from the brain and descend all the way through the spinal cord, goes to the lower body, they are dysfunctional, and then the epidural stimulation can result in excitation of those descending sympathetic pathways. So it can result in excitation of stimulation of those pathways, which allow brain a better supraspinal control. So our brain becomes in a better position to control those pathways, or have also better supraspinal control as a result of the excitation provided by the stimulation. Then at the same time, the excitation of interneurons that receive input from those pathways. So I have to go back to this slide. So there are a lot of interneurons located in the spinal cord between motor and sensory neurons, right? So once we see the excitation of the posterior column, we also see the excitation of the interneurons located inside in the middle of the spinal cord. So those pathways can also play important role in the blood pressure regulation, for example. So those pathways, or those interneurons, are being stimulated. Then the third one is the excitation of preganglionic sympathetic neurons. So our autonomic nervous system uses two sets of motor neurons, the preganglionic and postganglionic. It can get a little bit more complicated, but a specific set of sympathetic neurons, which are responsible for directly responsible for blood pressure regulation, can be excited and regulated using the epidural spinal cord stimulation. So this is a diagram to see there is basically as a result of the spinal cord injury, there is disruption of there is basically no action potential, because there is disruption of those supraspinal pathways which start from the upper spinal segments or from the brain. The epidural stimulation basically results in restoration of the action potential. It provides extra missing stimulation to the lower part of the spinal cord, and it generates the action potential, which can then communicate with the other components of the autonomic nervous system, allowing patient to some control over their lost autonomic functions.
Dr. Nasir, can you help to explain what does it mean for the patients? Who is a patient who will benefit the most from using epidural stimulation to regulate autonomic functions? And what real life improvements does it translate to?
So most of the patients above the level of T6 and above, mostly patients with cervical spinal cord injuries, are prone to having what is called postural hypotension. So postural hypotension is when they suddenly move from one position to another position, the blood pressure levels drop because there is basically very weak vasoconstriction, or there are basically disrupted mechanisms which are responsible for blood pressure regulation under different circumstances. And so epidural stimulation can help those patients with their postural stability and postural hypotension, where they are not prone to as a big drop in their blood pressure levels as without the treatment. So they can go through their daily activities without really getting concerned about drop in blood pressure level and getting dizzy. So it also improves, of course, the circulation in the lower body, which can improve their stamina and other functions and muscle function actually also.
From what we've seen in our experience, a lot of patients, they regain the ability to control the body temperature by sweating. I think this is worth mentioning because even if it seemed like a small improvements, for many patients, this is one of the improvements they've seen that probably matters a lot to them. So once again, I think it's important to highlight that epidural stimulation, even though our main goal is to restore the motor functions, it has a range of different benefits, including the blood pressure regulation, which could be a big change, especially for patients who are suffering from a low blood pressure or fainting. So with time and with the help of the stimulator, this could be really minimized or sometimes even eliminated.
This is correct. So the body temperature regulation is very closely related to cardiovascular function and blood circulation, because blood circulation plays an important role in body temperature regulation. And so once we see excitation of those supraspinal pathways or descending spinal pathways through the spinal cord, those autonomic neurons are being stimulated. It can also improve the autonomic regulation of autonomic thermoregulation, body temperature regulation in those patients. And they're not as prone to hypothermia, for example, or other complications as without treatment. So I would also like to briefly talk about the mechanism of action bladder function. So although the bladder function is not directly coming from the lumbar spinal cord or the major 7 spinal cord segments we stimulate, it's slightly located. It comes from the sacral nerve, basically, which is S3, S4 spinal nerves, slightly lower. The location of the bladder function center is slightly lower in the spinal cord, which is not our main target, but we can kind of like use the same electrodes to divert the electrical currents to the lower segments of the spinal cord to also try to reach the sacral nerves responsible for bladder function. And so the lumbosacral spinal cord stimulation activates autonomic and motor spinal cord circuits that are responsible for urinary tract, external anal sphincter, pelvic floor, and bladder and bowel function in chronic spinal cord injury patients. So basically, the sacral nerve neurons, which are normally at S3, S4 level, are responsible for sacral nerve, which is responsible for bladder, bowel function, then sexual function in individuals. So once we stimulate the sacral neurons using the epidural stimulation, it can also improve the bladder, bowel, and sexual function in those patients. And so this is what basically. So for example, if we use this configuration in some of the patients, so the dark electrodes are the positive negative electrodes, sorry, the gray are positive. So basically, these are the active 4 active electrodes and the lowest part of the epidural stimulation array. Once we activate those lowest electrodes after epidural stimulation implantation, it may be able to stimulate the sacral nerve motor neurons or autonomic neurons located in the sacral spinal cord, and this can improve the voiding capacity. It can improve, basically, it can increase the capacity of the bladder. It can also result in stimulation, contraction in the bladder muscle. So bladder itself is a very big muscle. So once the electrical stimulation is provided to the bladder, it results in contractions, and it can help patients to basically during the voiding or evacuation of their bowel function, also the same configuration of electrodes. So in short, with the help of epidural stimulation, we can also aim to target the part of the spinal cord responsible for bladder, bowel, and sexual function in many individuals.
Dr. Warris, I know with epidural stimulation for motor functions, it's safe to say we almost see instant results, right? There are some motor functions coming back. Usually in the beginning, we see muscle contractions, but it quickly translates into more controlled movements. What is the timeline to see the results in bladder functions, and what would be the timeline to see some changes in the bowel functions?
So unlike the somatic motor function or the skeletal muscle function, where we see immediate recovery, immediate contraction, it may take some time for the stimulation to regulate bladder and bowel function. So we are expecting a good recovery in many patients in the longer run, basically over a period of few months or few years. So we are not expecting immediate response, unlike the other muscles, because it would take a continuous long-term regulation of those spinal cord segments which are responsible for bladder and bowel function. So I would say the timeline is 6 months to a couple of years, maybe, in those patients where we may start to see a more significant changes or more permanent changes in the blood pressure, bowel function, sexual function regulations.
We've spoken quite a bit about the bladder functions. Could you elaborate a little bit more about the bowel functions? We do have a separate program which is aimed to help with the bowel routine of our patients. How do we use it? When do we use it? And what is the benefit of having this program?
Sure. So for the bowel function, we can use 2 different methods. So first one is we can use the epidural stimulation to target the lower part of the spinal cord, sacral spinal cord, to stimulate the autonomic system, which is directly responsible for bowel function. The second one is we can use upper electrodes to stimulate the lower abdominal muscles, which can improve the mobility of the gastrointestinal tract. So if we can give strong stimulation to the abdominal muscles, it can help patients reducing the time period required for complete bowel evacuation. So we use both methods in many patients, but mostly we use a method to stimulate the abdominal muscles to improve the mobility. So these are the just third-party research articles, which are not very important to discuss here. So I think I will stay here just in case there are questions, so I can elaborate a little bit more. So I think that's it on my side, Ms. Hannah.
Thank you. We will stay online for a few minutes to take questions. If there are any questions, we will be happy to answer. For all of you who have joined us later during the webinar, I would like to remind you that you can watch the whole webinar on our Facebook page and also on our YouTube channel. If any of you watching today would be interested to have a more detailed conversation, we of course are open to individual consultations. These consultations are free. One thing we will need to proceed with the consultation is to receive the medical files from the patient. The most important medical document is your MRI scan. We usually require full series of the MRI images so we can understand the injury better. And once we know what the situation is, how the injury looks like, and know a little bit background about your condition, we will be able to confidently discuss the epidural stimulation or other approaches we have available for your particular case. So I would encourage everyone to get in touch and get a chance to talk to us privately and learn a little bit more about their injury, and also educate themselves about the spinal cord treatment possibilities today. We do have some questions, Doctor. I'm not sure if you can see them on your screen.
I do. The question is, if the location is placed on a higher level, like cervical level, where will be the stimulator be placed? So even for if we want to target, which we didn't talk today, the cervical spinal cord. So some patients, I can briefly actually talk just to elaborate more on the question. So some of the patients suffer from, unfortunately, very high like cervical spinal cord injuries where they suffer from complete or near complete quadriplegia. There are no hand function. So the aim in those patients is to restore the upper body function at the same time. So we use the electrical stimulation to stimulate what is called the cervical plexus or the cervical spinal cord. Around C7, T1 part of the spinal cord is responsible for hand and finger function. So once the stimulator is implanted at this level, the battery is also still implanted into the lower part. We can use longer lead basically. So the location of the battery will be the same for both applications, cervical and lumbar.
We also
how do we know?
About, sorry, we have a question about the battery. So the stimulator life is 9 years. You can use it for 9 years, which is a very long time to see continuous improvements. Usually, depending on how much you're using the stimulator, we recommend to charge it every day or every second day. The charging process is very easy. It's actually a wearable belt, wireless belt that you can put on for an hour or so, and your stimulator will be fully charged. We also have a question from Jessica. Do you have patients needing to return for device problems or continue with rehab? Well, the good thing is about the device is it's manufactured by Medtronic, which is a major medical equipment, medical devices manufacturer. So you will see the local representation of Medtronic in, I think, most, if not all of the countries. So if there is any problem with the stimulator, there is always a local support that can help to troubleshoot and help to solve the problems. However, yes, we do see patients coming back to us, especially after 6 months or 1 year post the injury, when we see that there are already some more permanent changes in the spinal cord, and maybe we need to reduce the amount of the stimulation that is needed as the spinal cord regenerates. So I think it's expected to pay us a visit again after some time after the original surgery. We call it remapping. It might be required for maybe 7 days of work to program and fine-tune all of the functions of the device. To do the remapping, you can come to any of our locations. We are in Thailand, in Mexico, and in India. So this can be arranged. This can be arranged quite quickly. Regarding the rehab, there is absolutely no problem to continue the rehabilitation in your country back home. However, we do encourage the patients to make all the rehabilitation arrangements before they travel for surgery with us, because rehabilitation and physical therapy is one of the most important components that contributes to the future improvement. So it will be, it doesn't matter if you continue the rehabilitation with us or you continue by yourself, as long as you keep going, we're good. Doctor, we have a question about the risks related to the procedure. I think this will mainly relate to the surgery itself. Could you elaborate this a little bit more?
Yes. So like any other surgery, there are some potential risks. Mostly it's related to the surgical procedure itself, which involves a small risk of infection. So after the surgery, of course, patients are exposed to microorganisms. So this can cause infection in some patients. We take all the precautions. We have very strong, very strict protocols to treat the infection and reduce the risk, but the risk is still there. So this is, I think, one potential risk. During the initial mapping process, some patients, particularly patients with cervical spinal cord injuries, may experience fluctuations in the blood pressure level. So this is not serious really. During the recovery process, again, it's not a complication from the treatment, but we see more spasms, more spasticity coming back in many patients, which is a sign of more stimulation, more muscle contractions going on. So this can also be experienced by many patients, more spasms, more spasticity, which is again not a complication. Some
Jessica
patients will experience back pain and headache, fever after the surgery, which are just very regular side effects with any kind of surgical procedure.
Jessica is also asking, how soon after the injury do we want to see the patient? I think this is a good question, because we actually do treat patients in very different stages of their injury. One thing that is important, that the injury should not be acute. So usually we would recommend to contact us for medical evaluation at least few months after the injury. And this is also the ideal time to receive the treatment, maybe within the first 6 months or 1 year after the injury, when the spinal cord is still trying to regenerate, when the injury is fresh. But so this would be the best time period for us, maybe the first 6 months to 2 years. At the same time, we do treat a lot of patients with older injuries. For those of you who joined us a few weeks ago, you might have joined the webinar we had with our patient Barry, who is one of the patients with oldest injuries we have treated so far, approximately 25 years post-injury. So there are no limitations. Of course, there's a benefit of coming to us earlier. We will see the results much quicker. But even with older injuries, we can see similar outcomes. It will take a little bit longer time and a little bit more work to build on the muscles, regain the lost muscle mass, but it's possible almost any time after the injury. We also have another question about the treatment price. It really varies about depending on the location. The surgery starts at $70,000 to around $100,000. The stay is 35 days. This is including the epidural stimulation, more than 120 hours of the device mapping that we discussed in detail today, and also regenerative treatment, which is the stem cell treatment. Doctor, there's another question. Is it a guaranteed procedure when you will see improvements in certain areas, let's say autonomic functions, or does it depend on the injury?
So we spend quite a bit of time for medical evaluation. Of course, certain patients are better candidates than other patients, and we have, we discuss during the evaluation process, and we have one-on-one consultation with each patient to explain their individual chances of recovery. I don't think it's safe to say that is granted. Of course, we cannot guarantee the recovery, but I think depending upon each patient's condition, we can have a fairly good idea about the expected recovery. And we see a recovery in most of the patients. Some sort of functions do come back in most of the patients we have treated.
Adele is asking about her son. He's 34 and his injury, and he had his injury diving in the pool. He's incomplete C3 to 5, and it's been 8 months. When is the best time for him to be evaluated? Adele, I would say get in touch with us anytime. This is a very good time for the evaluation. We would love to see his MRI scan, and then of course we can arrange a meeting with you and your son where we can discuss what can we do in his case a little bit more in detail. He's an incomplete quadriplegic. It will be important for us to understand what his goals are. If his main goal is to regain the hand functions, which is also a possibility with slightly different application of epidural stimulation, where we would implant it in the cervical plexus, which can help him to regain some independence in terms of being able to hopefully feed himself or push his own wheelchair. So it all really depends on his symptoms and his MRI scan. So reach out to us. We will be happy to talk in more detail. Wari Tamara is asking, why is the procedure so expensive when most of the patients are on disability? Tamara, the truth is we're trying to keep the price as low as possible. The stimulator itself, just the device, is probably the most expensive component of the treatment. The price of the stimulator itself is more than $30,000. So of course it also affects the treatment price. Please don't forget that the hospital stay is also 35 days. So even though, yes, it's quite expensive, we know that we are doing our best to always try to bring the price to the lowest possible levels for our patients. This is why also we have the one of our locations in India where the medical care is a little bit cheaper. So this is also to help patients to receive this treatment. At the same time, I think it's important to highlight that whenever this treatment becomes mainstream, whenever it becomes available in Western countries such as US or Canada, we already know that the treatment price is estimated to be at least $300,000 to $500,000 for one surgery. So you can see that there's actually a big difference between what we try to achieve and what the price will be once the treatment is FDA approved and available in other countries. Adele, yes, the 70 to 100,000 includes everything, the accommodation, therapy, the stem cell treatment, of course, the surgery itself. We will also provide patient meals and airport pickup, all the tests, another MRI scans. So it is a complete package. Doctor, we have a question from an anonymous attendee about the spasticity. Can you work to reduce the spasticity and pain with this procedure for a cervical lesion?
Mm-hmm. So for pain and spasticity, if the spasticity is in the lower body, although it's from the cervical lesion, it can be controlled using the stimulation. So we have developed a few methods basically to use the stimulator to regulate those pathways which produce spasticity. So although the spasticity may go up slightly during the first 6 months or so, but the long-term use of the stimulation can help with controlling the spasms and spasticity and also the nerve pain. Particularly if the source of the pain is closer to the implantation site, it can be treated or reduced in severity.
Let me see if we have any questions pending. Can the stimulator be used while charging?
It can be used, but I mean for some functions. But I mean mostly patients use during their training session, for example, when they're walking or taking steps or training different muscle groups. It's not really recommended, and I don't think it's required because it takes around 1 hour, between 1 and 2 hours, depending upon to fully charge the stimulator, right? So I think it's possible, but not generally recommended to do.
Mm-hmm. We have a question from Nawami. What to do if 3 points are injured in cervical, thoracic, and lumbar points? I would say, Nawami, it would be best if you could share your MRI scan with us. We will need to understand a little bit more in detail what your situation is, and then we will be able to explain everything to you, what kind of approach we can take. We can consider 2 stimulators, we can consider combining different treatments. So there is no simple answer to your question. It would be best if we could know more details. Adele is asking, when is this expected to be in the United States? It's hard to say, but I think maybe within the next 10-15 years should be possible. Mm-hmm. Okay, I think there are no more questions for today. However, if any of you have any more questions, please feel free to leave them in comments or contact us directly through Facebook or through our website, epiduralstimulationnow.com. We have a dedicated team of specialists who will be able to take you through the medical evaluation process and explain everything step by step. So of course you are most welcome to get in touch, and we will be happy to guide you through the possibilities one by one. Mm-hmm. Doctor, it was a pleasure.
Yes.
Okay.
Just one last question. I think someone is asking about if this surgery is recommended for patients with complete spinal cord injuries at T6 level. So the level of injury T6 it's actually a good level because they have a good upper half of their body functional. In terms of the complete injury, it depends whether it is anatomically complete or functionally complete, right? So in most of the patients, it's just anatomically incomplete. Some part of the spinal cord is still intact, but functionally complete injury. So that can be treated with epidural stimulation, yes, for sure.
Right. In fact, we do treat both patients with complete and incomplete injuries. As long as the spinal cord is not transected, we can proceed. So this is not a concern. Actually, a lot of our patients, they come to us with absolutely no motor functions, no sensory functions below the injury level, and we are able to see very good results with them. Okay, one more question. Adele is asking to repeat the locations. Our flagship clinic where we originated is in Thailand. We have been operating here for the last 6 years. We also have a facility in Mexico. This is the 2nd year it's operating, and a facility in India. Mm-hmm. Okay. Thank you very much, everyone, for joining. Thank you, doctor, for the in-depth explanation. I think it was very interesting to see and understand about epidural stimulation a little bit more from the scientific point of view. So once again, this webinar will be saved, so please feel free to come back to this in the terms you are looking for more detailed explanations about the mechanism of action. And of course, we're available to talk anytime. Thank you, everyone. Thank you, doctor.
Thank you very much. Thank you, everyone. Thank you.
Thank you. Bye-bye.